Good afternoon, everyone, and welcome to Open Classroom. I'm Janet Gillow, Director of Professional Development for the Brown School, Washington University in St. Louis. So glad to have you as part of today's Open Classroom conversation. Throughout this webinar, as always with Open Classroom, you are muted. We cannot see or hear you, but we love to bring the audience into the conversation. So please do feel free to use the chat feature. For those of you joining us on Zoom, you can send in your questions, your comments, and we will bring you into the conversation as the webinar goes. I want to acknowledge my co-host, Cynthia Williams, our Assistant Dean for Community Partnerships. Cynthia is here to help moderate the chat. And then when we get to the Q&A portion of today's program, she's going to help represent you in the room. So before we get started with today's program, I just want to let you know what else we have coming up yet this week. It's a busy week for us here at Open Classroom. On Wednesday, so that's tomorrow, same time, 12:30 Central, Dr. Adia Wingfield is giving a presentation called Flatlining, Race, Work, and Healthcare in the New Economy. And then on Thursday, again at 12:30 Central, Brown School alum Nikki Doty is giving us a presentation on education in the era of COVID, sharing examples of what City Academy has done to adapt their educational model during this season. So if there's still time to sign up, if you'd like to join either of those conversations, please visit our website. So pivoting our attention to today's conversation, our speakers today are part of a larger team, I think it's a team of 6, that conducted an exploratory analysis of mitigation efforts in the early days of the pandemic. So we're joined today by Drs. Ruopeng, who's an assistant professor at the Brown School, Timothy McBride, who's the Bernard Becker professor at the Brown School, and Danlin, who is with Montclair State University, here to share their findings, COVID-19, an exploratory investigation of the impacts of the mitigation interventions in the U.S. Please welcome our distinguished panel.
Thank you so much, Janet. Good afternoon, everyone. It is our great pleasure to present our recent study on state COVID-19 mitigation policies in the US. So 2 months ago in September, we presented the first part of the study, which examined the determinants for implementation timing of state COVID-19 mitigation policies. And today we'd like to present the second part of the study, in which we report the methods applied and findings pertaining to the estimated impact of various mitigation policies in the US. In case you would like to take a closer look at the paper has been published in the journal Research on Social Work Practice. Dr. Shenyang Guo, professor at the Brown School, led the study. Other contributors include Professor Tim Bright, who joined us today in the panel. He's from Brown School, and also Professor Danlin Yu at Montclair State University. Also, Mrs. Lin Yunfu and Mrs. Yuan Yang at the Brown School to join us as contributors. As of November 15th, 2020, by yesterday, the day before yesterday, over 11 million people in the United States have been infected with COVID-19, and over 246,000 have died. Over the past week, there has been an average of 150,000 cases per day, an increase of 81% from the average 2 weeks earlier. Case numbers are spiking across most of the United States, leading to warnings about full hospitals, exhausted healthcare workers, and potential lockdowns. As conditions worsened and winter approached, the mayors of Chicago and St. Louis imposed even stricter limits on gatherings. And in Oregon and New Mexico, governors ordered residents to stay at home. In both rural countries as well as major cities, infections continue rising to fearsome new levels with no end in sight. The social distancing is an essential component of a public health response to infectious disease outbreak. A recent systematic review of influenza pandemics found that by isolating ill persons, contact tracing, quarantine exposed persons, school closures and workplace closures, and avoid crowding, distancing help reduce transmission, delay transmission, and also reduce epidemic peak. A study in China found that among cases known to have traveled from Wuhan city before January 23rd, the time from symptom onset to confirmation was 60.5 days. And for those who traveled from Wuhan city after January 23rd, when more active surveillance was in operation, the interval was reduced to 4.8 days. This data suggests that to prevent the spread of the COVID-19, policymakers must implement mitigation strategies if they choose to do so in a speedy fashion. In the absence of speedy implementation, the prevalence is likely to increase rapidly. Therefore, the timing of enacting mitigation interventions play a vital role in public health. Given that patients during incubation period are asymptomatic, responding to confirmed cases quickly has potential to make a significant difference in subsequent disease levels. On March 13, 2020, the President of the United States declared a national emergency to combat the virus pandemic. Following the declaration, about 42 states and Washington, D.C. enacted stay-at-home orders, with California starting the earliest. That was on March 19, 2020, and South Carolina starting the latest. That was by 5 p.m. on April 7, 2020. So these orders covered approximately 95% of the US population. Closely related to the stay-at-home order are various non-pharmaceutical containment interventions aiming to promote social distancing. So this study addresses two research questions. The first question pertaining to the determinants of the implementation timing of mitigation strategies. It asked the question, why did some states in the United States respond rapidly to the pandemic while others did not? Of various determinants, we are primarily concerned with the prevalence rate of the confirmed cases with respect to the time when each mitigation strategy was enacted. Delay in taking those interventions actions during this period may directly affect the speed and the scope of the COVID-19 spread. And the second question we try to answer focuses on the correlations between the timing enacting the mitigation policy and the incidence of COVID-19 cases and death. The impact study aims to address the question, is an initial response observed? Precisely during this period of the study, many states have begun to reopen the economies and public life. For example, by May 11th, 32 states out of the 42 states that implemented stay-at-home policies chose to reopen the economy. In light of those decisions, the purpose of this paper is to explore the initial impact of non-pharmaceutical mitigation interventions in the event that reopening the economy is associated with a second wave of COVID-19 disease and a second round of mitigation may become necessary. And now let's move on to talk about the study window. So in the study, we define the enactment of social distancing strategies as the exact hour at which a mitigation intervention was implemented, as stipulated by state government documents. The study window is defined as the period from the time when the national emergency was declared to the time when the latest enacting state issued a stay-at-home order. So to be more precise, the 0 hour for this study is 12 p.m. on March 13th, US Eastern Time, and the ending hour is 6 p.m. April 7th, Eastern Time, which is 1 hour after the last enacting state, South Carolina, that implemented its stay-at-home policy. States declined to issue a mitigation order are considered censored at 6 p.m. on April 7th, 2020. So the study period is within this 25-quarter of 25 days or 606-hour window. So we studied not only whether a state enacted a mitigation intervention and the type of intervention, but also the exact times at which these interventions were implemented. The timing of the national emergency is a natural starting point for the study because before that date, none of the mitigation strategies were enacted in the United States. Here, a special caveat should be put on the word zero. It does not mean that the COVID-19 pandemic started at that point, because as Anderson pointed out, most countries are likely to have spread of COVID-19 at least in the early stages before any mitigation measures have an impact. And now let's talk about the mitigation policy identification and how we classify them into different types. So we conducted a qualitative content analysis that we analyzed a large quantity of text data from government documents. And we have two brilliant students, Yuan Yang and Lin Yun Fu, who conducted the quantitative content analysis. So we examined all relevant documents, a total of 1,470 executive orders pertinent to the social distancing orders from the state government websites for all 50 states and Washington, D.C. And a content coding analysis was performed by these two young scholars. Review and coding guidelines were developed in advance. So the two reviewers separately examined all the documents and resolved discrepancies in coding through a discussion by consensus. Considering variations across states in the frequency of use of alternative social distancing strategies, and also consulting the prior literature on social distancing, we extracted information on 9 different types of mitigation interventions. So we'll go over these 9 different interventions one by one in the next slide. And the exact timing to implement these 9 non-pharmaceutical interventions, namely the hour when a specific strategy was implemented, was recorded. A state that did not enact a particular intervention by the end of the study window, which is 6 p.m. on April 7th, was considered censored for the strategy and was coded as having the longest time of the 606 hours on length of time it took to enact the matter. And censoring under the current setting refers to the fact that the event of interest, namely the intervention policy, did not occur by the end of the study window, but might occur in the future. And now let's talk about the 9 mitigation interventions. So the first mitigation intervention pertaining to stay-at-home order. So we coded the time in terms of the date and hour of orders issued by governors to urge or require all residents to stay at home except for essential activities. And in some states, it is also referred to, for example, shelter in place or safer at home order. And the second mitigation intervention is strengthen stay at home measures. So we coded the time in terms of date and hour that more restrictive social distancing strategies, including adding enforcement of stay at home order and, for example, grocery shopping limits, were issued. And the third time is public school closure. So we coded a time that governors formally closed all public K-12 schools. And the fourth one is all school closure. We coded a time that governors formally announced the closure of all public as well as private K-12 schools. And the fifth one is the restaurant and bar limits. So we coded the time of the first formal order that required the closure of on-premises food and drink consumption and only allow delivery, drive-through, or carry-out options. And number 6 is the large gathering ban of more than 10 people. So this coding captured the date and time that state first announced a prohibition of public gathering with greater than 10 participants. And number 7 is large gathering ban of any size. So this coding captured the date and hour that states officially prohibited public gathering of any size. And the 8th intervention is the non-essential business closure. And we coded the time that the governor formally ordered closed all non-essential business. And here, a caveat is that we excluded those states that only issue non-essential retail business closure orders. We also excluded those states that did not prohibit personal care and grooming business. For example, barber shops, hair salons, beauty salons, and nail salons, massage and tattoo. And finally, the last one is mandatory self-quarantine. We coded the date and hour on which the governors announced mandatory self-quarantine of up to 14 days for all travelers from other states. And we excluded those states which limit travelers from certain areas only. So those are the 9 different mitigation policies. And now this map shows the timing enacting the stay-at-home order. The most important strategy is the stay-at-home order, which was enacted by 42 states and also the Washington, D.C. The earliest state to implement this was California, as previously mentioned. So most states issued a stay-at-home order between March 23rd and March 28th. However, 8 states never chose to implement the order. So the map shows the geographic distribution of the timing categories with lighter colors indicating earlier enacting of stay-at-home orders. As we can see, there are a lot of variations in the timing orders, and some states choose never to implement one. And this is the detailed table showing the timing of mitigation interventions by intervention type. So the table reports the detailed information about those mitigation interventions for all 50 states and Washington, D.C. The most frequently invoked intervention was public school closure, which was enacted by all 50 states and Washington, D.C. Most states issued a school closure order between March 13th to March 18th. And the second most frequently invoked intervention was restaurant and bar closure or limitation, which was issued by 49 states and Washington, D.C. A strengthened order refers to mitigation more restrictive than stay at home, including the enforcement of stay at home and the grocery shopping limits. And here, as shown in this table, only 5 states issued a strengthened order. And now let's briefly summarize the determinant study because this part of the study, as the first part, was reported in the previous open classroom setting. So here we just briefly capture what was covered in part 1 of the open classroom. So we found that COVID-19 prevalence rate, population size, and employment proportion of uninsured in the state, poverty level, and also economic development level measured by the GDP per capita, and also proportion of minority people and public health infrastructure. They all predicted the timing of state-level mitigation policy interventions. For example, COVID-19 cases per 10,000 population at a time 1 day before the enactment was negatively associated with the hazard of enacting the stay-at-home order. And GDP per capita in 2019 was positively associated with the hazard of enacting the stay-at-home order. And the percentage of uninsured in 2018 was negatively associated with the hazard of enacting the stay-at-home order. Here, we want to emphasize that contrary to our hypothesis, we found that states with a lower prevalence rate of COVID-19 reacted more quickly to the outbreak compared to states with a higher prevalence of COVID-19 rate. And this finding is statistically significant for all models. It means that some states may have missed optimal timing to implement social distancing. And now let's move on to report the outcome measures used in the impact study. So the study of interest for today's session. So the outcome data come from Johns Hopkins University coronavirus data stream that we combined the WHO and CDC case data. So based on the original input data, we employed 9 variables in the investigation, 9 outcome variables. And they are cumulative cases, cumulative death, new cases and new death, and cumulative deaths per 10,000 population, cumulative new cases per 10,000 population, cumulative new death per 10,000 population, and death rate defined as the number of cumulative deaths divided by the number of cumulative cases. So those 9 measures are computed as of the time of the study and may underestimate the actual case and death. So this is definitely a major data limitation. And the study employed daily counts on each of those 9 outcome measures from March 11th, so 2 days before the national emergency was declared, and to April 15th. So that was 1 week after the last state enacted the stay-at-home order. And now I will transition and hand it off to Dr. Danlin Yu, and he is going to talk about the methodologies applied and also the results, the main findings coming from the second part of this impact study. Dr. Yu, could you unmute yourself?
Thank you very much, Dr. An, for your introduction here. And this is Danlin Yu from New Jersey. Yep. All right. I'm going to strictly focus on what I have contributed to this study on the methodological part, how we have organized the data, how we analyze the data, and why we should use this type of analysis, what type of result I got eventually. Dr. Yang, I would need your assistance to move the slides for me. But in cases, this is what we have initiated. After Dr. Gore has initiated a survival analysis, we're trying to find out what those social distancing measures, the 9 social distancing measures that Dr. Yang has introduced, how they are going to have any kind of effect on the cases, new cases, or accumulated cases, death rates, etc., on all those outcomes. And apparently, for any of you who have taken elementary statistical courses, you probably make this association that regression analysis is probably very well suited to study the impact of actions and outcomes. And those actions are what we call the social distancing measures, the 9 social distancing measures: stay at home, close ban large gathering, etc. And the outcomes are just what Dr. N introduced, the 9 outcomes. So we want to see whether, answer 2 questions basically, whether or not those social distance measures actually have any kind of impact on the outcomes, on the accumulated death, the new death, accumulated cases, new cases, and or the proportions or death rates, etc. So that's our purpose. Second purpose is trying to find out how, if there is any kind of significant impact, such impact would be. How we're gonna, well, apparently regression analysis is very well suited to study this kind of question. The data we assembled at this moment, really, from my eyes, I'm a trained geographer, I'm trained geographic and data analyst. As a matter of fact, this data is kind of like a treasure to me. It constitutes a set of what I call the geographical panel data. So, in other words, this data is collected over geographical units, states of the United States of America, but it also constitutes longitudinal data, time series data for 36 days. Right? So this is what we have. The days are as the temporal interval. Dr. Ann, please move to the next slide. Thank you. So before we jump ahead and analyze the data at its raw format, we do some exploratory analysis and take a look at the data. First, we found, well, apparently because of the reporting, because this is a pandemic, it's a disease, although it's widely spread, infectious, but it is not like everybody's going to get it. So during the stop period, we found this data is characterized as a zero inflated. That is highly skewed to the left, if you say so. So without giving you too much detailed, complicated explanation of how we process data, suffice it to say, we found that the 9 outcome and the social distance measures are pre-processed via the rank-based inverse normal transformation approach that was recently proposed to specifically propose to deal with the zero inflated data and highly skewed data. So the purpose of this INT method is to make the data more normally distributed. And as many of you probably know, that normal distribution is pretty much like a norm for any type of statistical analysis, specifically for regression analysis. In so doing, once we are able to do the transformation, we actually are able to account for both the time variant and time invariant factors. Dr. Ann just mentioned the GDPs, the unemployment rates, etc., etc. When you evaluate the impact of social distance measures on those 9 outcomes. So we have done that. Again. All right. Well, from a geographical perspective, when we are initiating any kind of analysis of the data that was collected over geographic space, well, many agree since 1970s that the least square based calibration approach that is very common in the world of econometrics, social statistics, or in the world of statistics, frequency statistics, the least square based calibration approach becomes no longer valid because of the spatial, so-called spatial autocorrelation in outcome variable, and more importantly, in the residual. Okay? Well, in the outcome variable is somehow equivalent to in the residual, the spatial autocorrelation. Well, the problem for spatial autocorrelation in the residual is that the residual becomes no longer independent, or in other words, the residuals are not IID anymore, independently identically distributed. So it's not IID anymore. We cannot really use the residual to derive a variety of the inference statistics at all. In this case, we have to shift from the least square based calibration approach to maximum likelihood based approach. And the maximum likelihood based spatial regression approach are the viable alternatives. And that is what we have applied in this particular analysis. Well, without giving too much details regarding how the spatial regression is to be calibrated and how it is supposed to be gauged or estimated, etc., etc. I'll just give you the bare bone discussion of spatial autocorrelation or spatial regression here. We did some statistical tests to suggest what type of spatial autocorrelation might be more likely to impact on the analysis. Now, in general, there are 2 types of spatial autocorrelation that might impact our analysis. The first type is the spatial autocorrelation in outcome itself. Okay. The second part is the spatial autocorrelation in the residuals. and the residuals. Although I have said spatial auto correlation in the outcome is kind of equivalent to spatial auto correlation in the residual, but there is an additional element in the spatial auto correlation in the residual. That is because the residuals also carries the task of receiving all the missing predictors, which you have to believe that there are a lot of missing predictors in our current regression analysis, since we are only focusing on social distancing measures impact on the nine outcomes. Right? We are ignoring a lot of other potential temporally varying factors. We did not include that, and those factors will evidently will eventually fall onto the regression's residual. And those residuals, those predictors, those omitted predictors, might also be spatially autocorrelated. And that is also one of the reasons that can cause the residual to be spatially autocorrelated. So, although spatial autocorrelation outcome can cause spatial autocorrelation in the residual, but there are more reasons for the spatial regression model, for this regression model's residual to be spatially autocorrelated. So we need to conduct some kind of statistical test to say which ones might seem to be the dominant force that makes the residual to be spatially autocorrelated. That then, okay, and also we conducted the so-called Holtzman's specification test because we are having a set of panel data to see if we are going to treat the individual effect as fixed or random. So we conducted the Holtzman specification test as well. And the Lagrange multiplier test, which was used to test whether or not which particular spatial autocorrelation dominates the model. And apparently our test suggests that it's not very surprising, the spatial error, in other words, the residual, the spatial autocorrelation residual is the dominant spatial autocorrelation that impacted the model. And also the individual random effect instead of the fixed effect is more appropriate based on our data. Hence, eventually we come up with this based on the statistical test, spatial error individual random effect panel model. Well, it's a mouthful here, as you can see. But this particular model produces the most consistent results. And this is the model that we're using to report our results today's open classroom. Okay. Thank you. Their analysis, the results, well, I did not present the table or the figures here. It's all in our paper published. Dr. Yang has first introduced there. So for those of you who are interested, please refer back to that paper, to the table 3. I think specifically is that. We're just going to jump right into the results. The timing, based on our analysis of when the stay-at-home order was issued, suggested a special clustering pattern. Spatial autocorrelated test of the timing when the stay-at-home order was issued suggests that the timing of the issuing stay-at-home, that was the previous figure Dr. N showed you, might have a clear spatial clustering trend in which one state is more likely to enact the stay-at-home order if its neighbors are enacting the order and vice versa. If the state was not really enacting a stay-at-home order, well, its neighboring states probably are not going to do that too. You probably paid attention to there are a bunch of states in the Midwest, which did not even enact a stay-at-home order at all till the end, and a bunch of southwestern states, okay, did not really, well, issued the stay-at-home orders fairly late, but states around California seems like they are, well, kind of initiating the stay-at-home order fairly quickly. So were the states in our area, in the northeastern United States of America. So there is a clear spatial clustering pattern there, and that apparently gives us an idea that even the social distancing measures have some special characteristics that needs to be included, needs to be considered in the modeling procedure. Okay. Right. From the model, we found not all the So social distancing measures actually worked well, had a significant effect on the 9 outcomes. As a matter of fact, they are only about like three out of the nine outcome. Social distancing measures have a significant impact on a variety of different outcomes. Only 3 out of 9, I believe. And more importantly, it was found from our model that the stay-at-home restrictive order, that particular stay-at-home restrictive order, does not seem to have any significant impact on any of the 9 outcome variables. Okay. This was a bit surprising. Just imagine that stay-at-home order, when it was first enacted, was regarded as a big thing. Okay, everybody has to stay home. Right, you cannot go outside to prevent the spread of the infectious disease. And it was supposed to be a important mitigation strategy, the non-pharmaceutical mitigation strategy other than anything else. It was supposed to actually the first thing, it's like the first line of defense against the infectious disease. But our model suggests, at least during this period of time of our study, this particular order does not really work well. Does not really work well. Well, our speculation in this research is that this particular stay-at-home order might not necessarily confine people from contracting one another, since the order is more like the opposite of good work. Well, I don't know about you guys, but when the stay-at-home order was enacted in New Jersey, trust me, a lot of people took that as an opportunity for vacation. Right? It's not really like, whoa, we're gonna stay at home. We're gonna quarantine ourselves, to confine ourselves within our doorsteps. We're just gonna, hey, take this time, not going to work, to do something else. And that make things worse. That's one of the speculations. So it might not be a good measure in our case. Whether or not a state enacted stay-at-home order might not be a good measure for social distancing as was intended. But there are the other three factors. Those 3 factors, including close of non-essential business, right? Ban large gathering. Well, that there are executive orders to ban large gathering that actually the law enforcement is going to enforce it, and the closure of restaurants. Those 3, if you think about it, comparing to the stay-at-home order, those 3 are more like, well, kind of like a forced you to not gather, forced you not to form large clusters, hence preventing you from, close contact. It constitutes the actual meaning of social distancing. So, well, those 3 strategies actually work pretty well. Hence, the from this particular result, we would say that the social distancing strategy, as proved time and time again, indeed works against the spread of the COVID-19. While strict stay-at-home order at its face value was initially thought as a means for social distancing, but it fails to achieve real social distancing nationwide because of, like I said, it's just at its it's a surface value. It's not really deep down, does not really prevent people from actually social distance. Right? But then.
Thank you so much, Dr. Yu, for your insightful comments and reporting of the findings and the results. So let me just briefly summarize the key findings here. So to date, the United States continue to experience high levels of COVID-19 cases. So this study offers 2 observations that may help explain why this is the case. So one is that some states may have missed optimal timing to implement social distancing. Based on prior research during epidemics, it is important to implement social distancing swiftly. And the key is not whether such measures should be taken, but when it is taken. And the second is that in the short run of 5 weeks, mitigation intervention should be expected to have only limited effects on slowing down the spread of the disease. Of 9 strategies as we examined, only 3 show some positive impact. Now, let me hand it over to Dr. McBride, who is going to offer us some policy implications.
Great, thanks, Dr. An and Dr. Wu. So I'm just going to make a few comments and then we'll open it up for questions. So obviously we did our paper several months ago based on some of the early months of the surge, and now the surge in COVID, and now we're sadly going through another surge in COVID-19. So which, you know, we didn't want to go through, but you know, some of us might have predicted this might have happened with some of the policy interventions that we were not doing at the national level. So as both the professors just said, our results showed it's important to have optimal timing for policy interventions, and some of the mitigation strategies have limited effects based on our findings, and some could be very effective. And just pulling out from our findings, we found 3 of them are particularly important among the 9. You know, the stay-at-home orders, school closures, and any gathering bans. And now that we're sort of in this late fall situation, one of the things you're seeing is some of the local governments are turning back to those sort of policies. I sit on the St. Louis Board of Health, in our St. Louis County is turning back to some of these policies, not to the stay-at-home orders yet, but we're, as many people have heard in the past week or so, they instituted a limit of gatherings of 10 persons or fewer. School closures are starting to happen at a pretty expanded basis around most of the country. We're not going to stay-at-home orders, in part for the reasons that Dr. Yu just mentioned. So we're sort of moving back towards what we saw in the spring. Given what we saw in the spring, stay-at-home orders seem unlikely. Some other policy interventions can be helpful. We've learned a lot since the spring, I think. Although I think we're not, as all of us know, painfully, we need more effective contact tracing. We're not doing it probably as well as we should, probably just because we just can't keep up with the 11 million cases we have in this country. We need more effective messaging. I sit on the St. Louis Board of Health. Messaging is crucially important. We've done some of that. We need to do more of it. We need to use big data. I think we've done a pretty good job of that, at least in the St. Louis area. We've learned a lot about doing that and analysis to understand these trends. You've seen some examples of it in this presentation, using data to analyze what's going on. We've made inroads on that. Frankly, one of the things I think we've learned in this pandemic is we were woefully unprepared to deal with this public health pandemic. But I think one of the things we put together now is public health data at the state and local levels in fits and starts. We need to do more of that. Some of the recent trends suggest that the problem's different early in the outbreak than it is now. All data suggests that early in the outbreak, especially out east, New York, Michigan, New Jersey, it was hitting older people more, nursing homes. Now all the data suggests that the problem appears to be younger people and gatherings of among younger people and such. So next slide. Yeah. Huge health disparities remain a huge challenge. We mentioned this in our article. The impact of COVID-19 as a huge disproportionate impact on low-income persons and people of color. Our study talks about this. Many people have talked about this. There's a lot of data that suggests this. I think we've only started to scratch the surface about how important this is. And we talked about some of this in our presentation. The COVID-19 case rates are higher for people of color, for African Americans, for Latinos, and we have a special seminar that deals with it here at Washington University. Understanding why that is, and then trying to deal with that problem is crucially important. You know, I think some of the reasons why that is probably got something to do with that low-income persons, African Americans, are probably more likely to be essential workers, nurses, first responders, and so on. It's probably got to do with housing conditions, poverty, lack of access to care, a whole host of social determinant reasons. But for whatever reasons, we're seeing higher COVID rates, and and we need to deal with that. The economic dislocation from COVID is huge, and it showed up in our study, and we talked about the implications of it in our study. Yeah, as I mentioned here, these numbers are a little updated from what we have in our article, and it's something that I've been fixated on and working on. The rise in the unemployment went up to 25 million. It's now down to about 10 million people remain unemployed. We have huge problems related to food insecurity, housing insecurity, and that was a big concern early in the pandemic, and I think it'll now rise as we are seeing the big peaks now in the late fall. And I would just point out, just sort of looking forward, that, you know, we're all sort of hopeful about what's going to happen with the vaccine. We've had some recent good news in the last week about the rolling out of the vaccine. If the news is correct, we may see a vaccine roll out, you know, later part of this year, early part of next year, at least for health workers. Then maybe the rest of us will get it into 2022. But the effective rollout of the vaccine is going to create a lot of challenges, a lot of logistic challenges, including messaging, including do we get it to everyone in the population that needs it? Not just high income people, but low income people, people across the whole spatial issue that Danlin mentioned. So we need to be thinking about the challenges that we talked about in this article with the vaccine as well. So next slide. So I talked about the differential impacts of the mitigation policies, mostly the health disparities, the limitations of the stay-at-home policies, and we're definitely seeing a relapse of the reopening now. And one thing we talked about in our article is the differences in state policies versus local policies. We didn't talk about it much today, but we clearly have a dysfunctional national policy. Much of the policy is being rolled out at the local level, and some states are having state level policies, and but a lot of this policy is being rolled out at the local level, and so that's part of the reason why Professor Yu talked about spatial issues and talked so much about that, because it's important to think about this in a spatial way around how it's being rolled out nationally, and not just state by state, but county by county. That's really how this is playing out nationally. Next slide. Right. Next slide, Ruopeng. Okay, are there any questions? Appears to be that we have some questions.
Yes, we do have one question in the audience. Thank you for your excellent presentation. Do you think that the non-effectiveness of school closure could also be due to a low prevalence of COVID in youngsters? If so, what's the implication to school reopening?
I don't know who wants to take that one. So the so could you say that one more time? Sorry.
Yes. Do you think that the non-effectiveness of school closure could also be due to a low prevalence of COVID in youngsters? If so, what's the implication to school reopening?
Yeah, that's a complicated one because, and I have a lot of school teachers in my family, not here in Missouri, but a lot of them in Wisconsin, where there's a huge outbreak. So it's true that small children and even teenagers are low risk, but since my family members are teachers and social workers, I'll tell you, they're extremely nervous. They were extremely nervous even before schools opened. So they weren't really that nervous about the kids. They were nervous about their coworkers. So they were nervous about, and so it's really, I think a lot of people sort of mistakenly worry about the kids coming, and, that is part of the risk, is coming from home, bringing it, spreading it. But it's really, I can tell you that one of my family members, literally before school even opened, they had a COVID spread in the lunchroom because people came in, they weren't wearing masks, and they had a COVID spread because people were like, I'm not worried about this thing, and it spread in the lunchroom, and then they had to shut the whole school down, and it was the teachers, and so that's really the problem. And so it's the mitigation strategy, as we know in the Brown School, really has to be spread. You have to do it widespread across staff, teachers, everybody. I'm not sure if I answered the question. I don't know if my colleagues want to jump in on that one. So, as reopening happens, that's going to, anyways.
Yeah, I completely agree with what Professor McBride just talked about. Just adding to that, I think the question is probably less about whether the school should open, but really, how the school should reopen, whether the school has the capacity to do that in a safe way, and whether the teachers and the teenagers and children really follow closely, such as masking all the time, and really keeping the social distance. So just from local schools, we have mixed observations. There are some schools that implement very strictly of the policies, and we see a low rate of prevalence and even no cases after a school opened for a while. But for other schools that don't do that so well, we see a spike and really the infection cases coming up.
And many people have talked about what federal government needs to do is help the schools. These, as we know very well at Washington University, this is not a low-cost event to actually, put in place a lot of changes to make this safe. So we have the resources at Washington University, thankful to do it, but a lot of schools across the country don't have it, and the federal government did not step in and help them.
There is a question from the audience. Is a national mask mandate feasible in the near future?
Every public health study I read suggests that masking is the number one thing we can do to reduce, COVID. So would it be helpful? Yes. Is it feasible? You know, people don't, unfortunately, we've made it political, and, you know, so feasibility means people are not always going to comply, but, you know, we need to message around that. So feasibility is not the greatest, you know, it's not going to be 100% compliance, but, you know, I would do it.
Reminder to the audience, we cannot acknowledge a raised hand. So if you put your question in the chat, that will be helpful. Also, to a question to the panelists, would you please summarize your original hypothesis and what your findings elevated? Would you do that for us, please?
You want to try that, Ruopeng? You're muted.
Yeah, sure. So our primary hypothesis is that we should ideally observe all 9 different policies, mitigation policies, have some kind of effect on the outcomes. For example, reducing the number of new cases or reducing the mortality rate. But well, contrary to our hypothesis, we only found 3 out of the 9 policies to have some limited impact.
You know, and I think a couple of things I would add to that is that might surprise people. And you know, well, first of all, I want to add in again a real shout out to Lin Yun Fu and Yun Yang, if I pronounce their names correctly. You know, what's really amazing about the study, and you should download it, is the amazing amount of work that they got, literally the timing of every policy in the United States up until the time they got it. So what's really cool is the timing to the day when these policies were put in place. So, you know, it may surprise you to hear that, well, you know, not all these worked. And so, you know, okay, so why is that the case? So we puzzled a lot over that. And it's probably because, as it's said several times in the slide, some of these weren't done at optimal timing. It was almost too late. So, you know, if you know, like in China, in Korea, and other places, they did them early and they did them, you know, in the proper order in time. And, you know, what really this, my colleagues can jump in and disagree with me if they want, but I think if you did these things in order in the right time, they might have worked better. But I think what I take away from this is we kind of were too slow at the switch. That's what I take away from this. Would you guys agree with that?
Yeah, well, I'm jumping on that one. Yeah, I agree with you 100% that we are probably enact some of the social distance orders too late and probably too narrowly. But other than that, I'll just add on to your discussion here. As I presented in the slides, also mentioned that, well, in regard to the question, with our what's our original hypothesis, Dr. Ang has already presented that. But with our model actually verify or validate those hypotheses, I would say partially indeed. Our general hypothesis would be saying whether or not the social distancing measures would have any impact on the COVID-19 spreading cases, or I mean spreading outcomes. And the model, no matter which part, after we take into account the spatial autocorrelation, the model actually says yes, social distancing measures does work against and curbs and prevent the spread of the infectious diseases in some degree. Well, in some degree, it's just social distance measures. That's why we call it NPI instead of a pharmaceutical solution. We have to wait until the pharmaceutical solution to finally fought to the back. Yet, in any cases, I think the model suggests that social distancing measures work. Well, some of the measures does not work, probably because of the how the measure was designed, such as the the one that I talked about in the slides saying about stay at home, which was a big one, which was a big thing. Everybody thinks that stay at home should be the best strategy, the one strategy we should look for as the equivalent to self-quarantine. but it turns out it's not. At least the data does not support so. And I don't know, I didn't do a nationwide survey, but based on what I observe daily, I would say, like I said, stay at home is not really equivalent to social distancing, not at all, at least at the very beginning. Stay at home is just the opposite of go to work. So people stay at home, and home was defined as a very broad concept, which is not really confined within this 2,000 square feet on the land. Instead, home becomes the opposite of a workplace. So every place is home. After you stay at home, you're taking vacation. That actually facilitates the spread of the disease, at least at the very beginning. And also extending a little bit from this question back to another question asking about would or not the wearing a mask would be feasible. Dr. McBride has already mentioned, it's probably the most effective things to do. Dr. Anthony Fucci has said that numerous times, and any sensible people is going to do that. The problem is, when the majority of the people are sensible in this world, there will always be people who are not sensible. And that is a fact that we have to deal with. And so we are not even feasible to wear a mask. Let's say if we are taking the wearing a mask, if we are labeling wearing a mask less with a political label, instead just purely put wearing a mask as a symbol of fighting back a dangerous, deadly disease, it might be feasible, but not wrong, as we have done in 1908 when that original Spanish flu caught the entire population of the United States of America and killed a lot of people. Yeah.
This always happens that an hour goes quicker than we can imagine. I really want to thank our panelists for bringing the science to our understanding of what's working and what's not. Some of the most important steps for us and our government to take going forward through some very difficult times that we hoped not to find ourselves in, and yet here we are. We are really at the hour, but I do want to ask Dr. McBride, did you have any closing comment that you wanted to offer on behalf of the group?
Sure. I was actually looking at one of the comments in the chat box, and it's a really good summary comment, and it pulls on what Professor you just said. Peggy says, we were too slow at the switch and then too fast to reopen, and it's about timing. And we were also, I'll just add on that, as we were a large country and we were inconsistent with our messaging and our policies. So I think, if maybe others would disagree, but I think that's part of our finding, I think, is relative to other countries. That's kind of the way I would see it, is we didn't move fast enough. We were inconsistent with our policies. We're inconsistent with our messaging. We didn't move fast enough. And with an infectious disease, then it moves pretty quickly, and then you can't get it back in the bottle. And now we're reopened, and we reopened too fast, and look at the curves. And now we're paying the price. That's what I would say.
Okay. Well, Drs. Yu, Dr. An, Dr. McBride, thank you so much for elevating this conversation for us. To my co-host, Cynthia Williams, thank you for facilitating and being in the chat. To our audience, please stay safe out there, wear your mask, and please join us again on Open Classroom very soon. We look forward to seeing you. Thanks, everybody, so much.
Thank you.
Thank you so much, John and Cynthia.
Thank you.
Thank you, everyone.
Thank you.